This is Dale Gregore, and she is a graduate of Westchester State College and Boston University, and she has 30 years of experience in medical speech pathology. She has taught undergrad and grad speech pathology for over 20 years at Westchester University and the University of Delaware. She's currently the program manager for speech pathology at Christiana Care Health System and oversees speech pathology at 2 hospitals, 1 rehab center, and 5 outpatient sites. So, welcome, Dale. Thank you.
Thank you. Hello. Thank you for coming here and learning more about things that are not just aphasia, things that can happen after a stroke that affect cognitive communication. I included this. It's in every room, and those of you who work for Christiana Care, you should know this by heart. It's like our pledge. And I included it because we do serve our neighbors as respectful, expert caring partners, and hopefully we'll be bringing some of that expertise and sharing it to you so that you can then bring it with and work with your patients. My background, as we said earlier, is a lot of years of experience, and throughout all of it, language and speech pathology and learning is at the core of our training. And I am a board-certified specialist now in swallowing. However, from all the years of experience, you can't discount the training that we have and the love that we have of language and the function of the brain. I do have to give kudos in that there are 4 board-certified specialists in swallowing in Delaware, and we all work for Christiana Care. So again, moving back and bringing the expertise and care of our stroke patients to the community, that's where we're here. Again, the comprehensive stroke assessment brings exceptional people into the care of our patients, and knowing how to communicate with your patient effectively after a stroke is key for quality of care. Hopefully you'll learn some strategies and techniques today that will better your communication and therefore better your care and the patient outcome. Today's presentation will include just an overview of some common disorders that can co-occur with aphasia. We all know aphasia. We've heard about it. It's the first thing you hear about. But there are other things that can affect communication. And I really want you to think about, if that patient can't follow that one-step command, is it a true aphasia? Are they having trouble attending to the information that you're presenting? Are they apraxic? Is it a memory problem? There's many things for why a patient cannot follow a command. I will go over 3 information processing disorders that affect their processing of information from sensory input. And then some new research that delineates the different types of memory impairments that can co-occur with the aphasias, as well as some interesting research opportunities that we have here at Christiana Care, partnering with Temple University and the University of Washington. So communication. What is it that sets us apart? What is it that makes us human? And it is our ability to communicate and express our needs and our wants verbally and through language. We think of our patients when they come into the emergency department, and the first approach to them is to do the NIH stroke screen, and perhaps we're doing the stroke swallow screen. So we're looking at language, we're looking at swallow, and we're going to assess what is their communication as well as their functional ability, their motor skills, and other areas. We know that we need speech, voice. We do need swallowing. We need language and cognition to help us communicate our wants and needs. So the team comes, we assess our patients. First thing we ask them is, what? Anybody? What's your name? That's it. Tell us your name. Date of birth. Can you count from 1 to 10? Raise your hand. We're barking all these orders at them, which perhaps they can or cannot understand after a stroke. So communication is the key, not only for our assessment, but for our treatments. There are different disorders that can occur from a stroke, and I like to describe each one of them. And this is my best and favorite time for me to include phonetics, which is a skill that speech pathologists are trained. We never get to use, but we like to write it, and it's a language in itself. Apraxia. So in rehab, we have different types of apraxia. It's an acquired motor disorder that can affect volitional movement. And in speech pathology, one might see a phonatory apraxia immediately after a stroke. If the person might cough volitionally or clear their throat or laugh, but when you say ah, they can't volitionally, that might be a phonatory apraxia. There's an acquired apraxia of speech. We have developmental apraxia with children, but perhaps acquired apraxia of speech that can affect their ability to volitionally produce language. So when we ask them to repeat words, is it comprehension or an apraxia that can affect their ability to do so? There are different apraxias. All the PTs and OTs in here know that we have limb apraxia. We might have constructional apraxia. In swallowing, we might have idiomotor apraxia, where you can't initiate the transfer to remove a bolus out of your mouth. Or idiokinetic. The transfer starts, but then it stops and the person's sitting holding food in their mouth. Motor planning can break down at any level. So an apraxia also affects communication. Dysarthria is a speech or voice disorder that co-occurs because of weakness. You can have apraxia and dysarthria together, but when one is dysarthric, it is due to motor weakness. So I can have a co-occurring central facial nerve palsy, cranial nerve 7. I might have cranial nerve 12 for tongue involvement, or 10, cranial nerve for affecting my voice and my swallowing. Dysarthria can go the gamut, same with your motor parameters of flaccid versus spastic or mixed. And if the person's voice is affected because of involvement of their respiratory system, that also can be as part of the umbrella of dysarthria. And then aphasia. We'll talk about more of that later, but aphasia is an acquired language disorder that can occur after a brain injury. We think of an acquired brain injury versus stroke. So TBI, who's the most famous person that you can think of that has had difficulty with language after a traumatic brain injury? Anybody? Oh, Dick Clark. Okay, there you go. That's one I hadn't thought about. There you go, Gabby Giffords. So listening to her speech, you can pick up those elements of an apraxia and clearly an aphasia. There's also dysphagia, which is, or you might hear it pronounced dysphagia, but difficulty swallowing, dysphagia. We look at swallowing in 3 stages, oral, pharyngeal, and esophageal. So from weakness or an apraxia, one can have difficulty with swallowing after a stroke. But the biggest thing that affects all of these is location, location, location. And combining the location of the infarct or hemorrhage, the degree of damage of the infarct or hemorrhage, plus concomitant disorders, that results in the severity and how we will be treating them. We know that what is controlled in the frontal lobe might be more of the motor, initiation, planning aspects, or high-level executive functions, to the parietal lobe with sensory integration, occipital lobe for vision, and temporal lobe for comprehension. From a fact standpoint, about 1 in 250 people may have an acquired aphasia. And I'm thinking that's about 1 person of all the attendees here today, which perhaps is more. Aphasia can occur from a stroke in utero for children, as well as an acquired stroke afterwards in adults. And as I said before, about 2/3 might be from stroke, or 1/3 of those with aphasia might have damage from head injury. It is more common than Parkinson's disease, CP, and muscular dystrophy. In itself, nearly 180,000 Americans acquire this disorder every year. These facts come from the National Aphasia Association and the American Speech and Hearing Association. So what is aphasia? Language is produced in 2 means. We have receptive language and expressive language. Receptive language is your ability to comprehend what you hear and what you read. And expressive language is your ability to express yourself through verbal means, speech, and in writing. And aphasia can affect both aspects. The severity, again, depends on location of the stroke and concomitant factors. what once was pure locationist in theory. The locationist said, if you have damage in one area, you will have one type of stroke. Well, now they're recognizing that the brain communicates with each other and that different lobes function in different ways, but they also interrelate. We know that in the frontal lobe, if there is damage in Broca's area, our speech will be more non-fluent. And why is that? Think about that. What else is housed in the frontal lobe? You didn't know that this was going to be interactive, and I apologize. That's the teacher thing. Pull you in. Why? What's also produced or housed or controlled in the frontal lobe? Motor planning. Thank you. And so therefore, if there is a disorder or infarct in the frontal lobe, speech production will be more non-fluent and what they call telegraphic. The function words might be there, but the articles may not. The comprehension generally is better than expression, but not always. And they're also finding, too, in Wernicke's, which is more of a temporal lobe disorder, their person might be fluent. That is called a fluent aphasia because it's not near the motor cortex. It's in the temporal lobe where more comprehension occurs. And these patients may have poor comprehension, poor deficits, deficit awareness or insight into their deficits. These are the ones that might speak fluently but in nonsense. And those are also the ones that therapeutically, if they aren't aware of their deficits, one has trouble treating it right away because they don't think there's anything wrong. There is the term global aphasia, and you've all heard that. And that's actually the term that therapists don't like because the connotation is that they are severely or profoundly impaired in their expressive and receptive language abilities. Hence, maybe there's no chance of cure, which I don't believe. And our approach here is to teach the patient and to help them compensate while we're remediating as best as possible. So let's look at some other concomitant disorders. Up top, and the first thing we might see in the emergency department is the aphasia, language difficulty. And underneath that, one might have, you're noticing that there's central facial nerve involvement. So there's a dysarthria. Their speech is slurred. It might be disfluent, etc. And perhaps underneath that is the apraxia. You're asking them to repeat things or do things, but it is difficult for them because maybe there's a motor planning disorder. Other disorders can also mask those true deficits. An agnosia, do they recognize the face? Do they recognize parts of their body, their limbs? Do they have a hemi-neglect or hemianopsia? What's their vision like? And are they aware that they're having difficulty or are they in denial? All these can affect not only our true assessment, but then our treatment of the patient.